dear colleagues. Welcome to my presentation about our coronary ablation strategy in a patient with vasovagal syncope. In the first part of my presentation, I will try to explain the theoretical background of our coronary ablation strategy, and in the second part, I will try to demonstrate a live in a box case in which we performed coronary ablation. The case was 24-year-old male and he had 16 syncope episodes in the last 3 years despite physical counter-pressure maneuvers. 4 of those episodes was seen in the last year under midodrine treatment. The patient was seen 2 other centers and electrophysiologists suggested pacemaker implantation to the case, but he refused it. After our initial evaluation, we also suggested pacemaker as an option, but the patient refused it again, and so we decided to perform coronary ablation in this case. In Turkey, we still cannot use loop recorders to demonstrate different component of syncope, so we usually use tilt testing to demonstrate different types of reflex syncope, such as cardioinhibitory, vasodepressor, or mixed type. In this case, you can see a typical cardioinhibitory type reflex syncope. At the beginning of the test, you can see an increase on heart rate due to sympathetic discharge, and then there is a stepwise decrease on heart rate, and finally a 14-second asystole. If you look at here, syncope episode was seen before occurrence of significant bradycardia or asystole in that case, and I think that this response may explain why classical pacemakers or even rate drop response pacemakers are not effective in some vasovagal syncope cases. As you know that syncope is a transient loss of consciousness due to global cerebral hyperperfusion, and we also know that a significant decrease on systolic blood pressure will cause a decrease on blood pressure at brain level, and it will finally end with global cerebral hyperperfusion or syncope. As you know that blood pressure consists of total peripheral resistance and cardiac output, so any significant decrease on heart rate or stroke volume will cause syncope at the end. If you look at the pathophysiology of reflex syncope after occurrence of any trigger activity, it will decrease left ventricular filling pressures, and it will increase on sympathetic tone, and it will cause a forceful ventricular contraction. And finally, it will stimulate C fibers. Stimulation of C fibers may cause 3 different responses. In the first part, you can see bradycardia or asystole due to parasympathetic overactivity, and this response is called as cardioinhibitory. In the second arm, you can see hypotension due to sympathetic withdrawal, and this is called as vasodepressor type reflex syncope. In the last arm, combined effect of both sympathetic withdrawal and parasympathetic overactivity cause global cerebral hyperperfusion, and this response is called as mixed type. As you know that classical pacemakers and even rate drop response pacemakers usually detect the event after occurrence of significant bradycardia, but as I mentioned in the previous slides, it will not fix syncope episode in some types of cases. So recently, manufacturers used to closed loop stimulation systems to deal with this problem, and these devices try to detect events in the earlier steps just during forceful ventricular contraction. Before performing coronary ablation, we usually want to see Holter recordings of the case, because you can also see significant sinusal asystole pauses episodes or functional AV block episodes, especially during evening times. In the present case, as you see that we see a lot of sinusal pauses and Mobitz type 1 AV block episodes, especially during evening time. So actually we believe that vasovagal syncope, carotid sinus syndrome, functional AV block, or some types of sinus node dysfunction and even vagal induced atrial fibrillation may be the different presentation of the same pathophysiological phenomenon, and I think that this topic should deserve investigation. Can we selectively ablate parasympathetic neurons? I think that this question is very, very important to understand cardioneural ablation idea. I like this figure very much from Pachon et al. And actually they concluded that in cardiac ganglia or in gangrionated plexus site, you can see neuronal body of parasympathetic system, whereas for other system you will only see axonal fibers. Recently, this paradigm was confirmed by Hanna et al. From Shiv Kumar's team, and by using immunohistochemical staining, they demonstrated that in GP site you can only see neuronal body of parasympathetic system. And as another anatomical knowledge, we know that neuronal body cannot be regenerated after any damage. So if you properly detect localization of those GP sites, your lesion in that site will be permanent in parasympathetic system, whereas in the other system your lesion will be transient due to axonal regeneration process at the end of long-term follow-up. If you look at the relevant literature about ganglionated plexus, you can see a lot of different anatomical naming or classification systems about GPs. But we believe that actually there is a quite similarity between those GPs according to their anatomical localization. So in our current approach, we believe 5 GP based anatomical localization system during cardioneural ablation procedure. According to our classification system, ganglion A is the head station for atrial parasympathetic innervation, and which ganglia is located between superior vena cava and aorta. And you can also see some neurons of this ganglia in higher part of right superior pulmonary vein. The second one is ganglion B, located between right atrium and right pulmonary vein, and which provides vagal innervation of sinus node. The other one is ganglion C, mainly located around coronary sinus, but some of neurons of this ganglia is also seen in lower part of interatrial septum, and which provides mainly vagal innervation of atrioventricular node. There are two different GP sites except for those ones. The first one is left superior GP. You can see it in here, mainly located between left superior pulmonary vein and left atrial appendage. The last one is ganglion left inferior ganglionated plexus, and you can see this ganglion in mitral isthmus area, and this site is just opposite side of Marshall tract ligament or Marshall tract GP. Although all these anatomical considerations, we should keep in mind that localization of GPs may demonstrate significant difference from one patient to another. So during electrophysiological study, actually you need a real targets to define their localization. With the same, different groups use different techniques. In the first one, you can differentiate normal atrial myocardium from ganglionated plexus site by using high frequency stimulation. I'd like to thank Maria Kim for these images about HFS application, and as you see that if you are in GP sites, your HFS application will cause either significant asystole or second or third degree AV block due to vagal discharge. However, if you are in normal atrial myocardium sites, your HFS application will not cause any significant effect on PR or RR interval. In the second method, Pachon et al. Used fast Fourier transform analysis to convert normal atrial electrograms to frequency amplitude curves. And by using this method, they defined two different spectral potentials type. In the first one, if you are in GP sites, you will see a heterogeneous and segmented spectrum by using spectral analysis. But if you are in normal atrial myocardium sites, your spectral potentials will be same with action potentials curve. In the last method, the great majority of groups try to ablate GPs by using empirical anatomic ablation in presumed GP sites. But I think that there are some limitation of all these techniques, and briefly I will try to explain some of them. For example, in high frequency stimulation, you should know that there is still no consensus for proper HFS protocol. Another limitation, it's a very time-consuming method. For example, in Kim's study, the mean HFS mapping time was 63 minutes. And also, criteria for positive response are not identical between studies. Another important issue, some groups like our group still perform cardioverter ablation without using general anesthesia. But if you think to use HFS application, you will need general anesthesia because it's a very painful procedure. Lastly, it may cause inadvertent atrial fibrillation stimulation during application. In spectral analysis, as I mentioned before, you need a converter, or you need to use fast Fourier transform analysis to convert electrograms to spectral potentials, and there is no integration with 3D mapping systems. In empirical anatomical ablation, you should know that you will know any clear ablation target during electrophysiological study. You will just perform ablation in empirical identified sites. Because of that, your ablation endpoint will not be clear in that technique, and you may perform larger ablation. So we believe that we need a new technique which is easily understandable, which is easily applicable, which is suitable with 3D mapping system, and if this system does not require any additional equipment, it will also decrease procedural costs. So we try to define a new and simple technique to detect ganglionated plexus during electrophysiological study. As a theoretical background of this technique, you can check this wonderful study by Lelouch et al., which was published in 2007. In that technique, by using vagal responses during RF application, Lelouch et al. Defined three different electrogram properties. Normal atrial electrograms demonstrated lower than 4 deflections, and fragmented electrograms. Both of them demonstrate higher than 4 deflections, and they divided these fragmented electrograms according to their amplitude as low amplitude fragmented electrogram and high amplitude fragmented electrogram. As you see in here, at the end of the study, they found that the best single predictor for vagal response during RF application was the number of electrogram deflection at the ablation site. The next most useful predictor was electrogram amplitude. So we think that if any site demonstrate positive vagal response during RF application, we think that this site actually should be a GP site, as like in high frequency stimulation application. As another clue, Pachon et al. Studied different bandpass filter settings and they compared this electrogram properties with spectral data, and they demonstrated that if you use 300 and 500 Hz as a bandpass filter, it will be correlate with spectral analysis data, and you can easily detect spectral potential sites by using this method. As you know that in our classical settings we use this one. So in our current approach, we try to define fragmented electrograms, both low amplitude and high amplitude fragmented electrograms on those classically known GP sites by using these filter settings. You can see some examples about electrograms, and you can see high amplitude fragmented electrograms, low amplitude fractionated electrograms, and normal atrial electrograms. As you see that here, actually both ganglion A and ganglion B sites are very close to ostium of right superior pulmonary vein. So you can also see pulmonary vein potentials in that sites. This is another example. You can easily differentiate normal atrial electrograms from fragmented electrograms. So in our current approach, we as an ablation endpoint, we try to completely eliminate all targeted fragmented electrograms during RF application. And as a procedural endpoint, we usually check heart rate response of the case to atropine administration. For example, before 24 hours ago, before the procedure, we first check rest ECG of the patient. For example, heart rate is 60 BPM during resting time, and then we administer 1 milligram atropine and check the increase on heart rate, and then we again 1 milligram atropine, and then we check the increase on heart rate. For example, heart rate increased 120 BPM at the end of atropine administration. So we should achieve this heart rate increase after the procedure, after cardiac ablation procedure, to say yes, we completely eliminate vagal innervation. Yes, now we can go to our live in a box case.